I'm Professor Ali Omrani. I'm an infectious disease physician and a professor of infectious diseases. I'm based in Doha, Qatar. I work within the Hamad Medical Corporation system. It's a set of hospitals that includes patients with less complicated to the most complicated types of medical and surgical problems. And I also contribute to academic work at Qatar University College of Medicine. Syndromic testing matters for both patients and for physicians. What patients want is for their physicians to be able to make a correct diagnosis as early as possible and for them to receive the most appropriate treatment as early as possible, because we all believe that this is the best thing for us to get better. And certainly syndromic testing allows and helps that to be achieved. Multiple studies have shown time and time again that with syndromic testing, physicians are able to pinpoint the specific cause of an infection much sooner and then be able to tailor the treatment for those individual patients much sooner. For the patient, this means less exposure to unnecessary antibiotics, earlier, better exposure to the treatments that they really need. So it takes away what they don't need and brings in what they really need. And we also have good data that tells us that those two, giving people the right treatment earlier, helps them get better earlier, and they're more likely to get better. So this is great for patients. From a clinician's perspective, it's quite the same essentially, but just looking at it from the other side of the bedside. So what physicians want for their patients is to be able to give them the right treatment as early as possible. And those tests help us do that sooner and for a larger proportion of patients. So one key important thing about antibiotics is that A, they save lives. That's a given. But inevitably, as we receive antibiotics, we kill bad and good bacteria at the same time. There's no way to differentiate. So if I'm taking an antibiotic because I need it, that antibiotic targets the bacteria or the bugs that are causing my problem, but at the same time, they're targeting other bacteria that normally live harmlessly within my system, mostly within my gut. So if I'm taking antibiotics appropriately, I'm still allowing resistance to develop. The problem becomes even more compounded if I'm taking antibiotics inappropriately or unnecessary. The damage is inevitable, but it becomes even worse if we're saying this inevitable damage is actually completely avoidable. So it's very important to tailor antibiotics to need. And that's where again syndromic testing and rapid testing comes in, because it allows us to calibrate those antibiotics much earlier. So we're giving antibiotics when needed and just as much as needed and for only as long as needed. And that would be the best of all worlds. So historically, let's say 2 to 3 decades ago, it became obvious to most clinicians that delaying appropriate antibiotic therapy results in us losing more patients. And then there was an imperative, a drive around the world, so-called surviving sepsis campaigns, and what those tried to do were to encourage physicians to give appropriate treatment as early as possible. We spent decades focusing on one message, and that message was hit hard, hit early. And now we're seeing the outcome of those sustained efforts. They were successful, but perhaps too successfully, I would say. So what happened was we veered towards giving more antibiotics, more broad antibiotics to most patients, whether they need it or not. So for example, there was a recent randomized trial. It tested a different topic, but it's relevant to this discussion. What the trial tested was a difference in complications in association with 2 different antibiotic regimens. Those 2 antibiotic regimens target, amongst other things, Pseudomonas, so we would call those broad spectrum. But it's very interesting, if you look at the population that was included in this study, it was individuals presenting to emergency department or ICU with a suspicion of an infection and then receiving those antibiotics. Very, very importantly, when you look then at the analyses and the details of those patients, you find that amongst this lot, who all received broad-spectrum antibiotics because that's what physicians tend to do. Only 5% were actually in ICU at the time they were enrolled. So the majority were individuals actually in the emergency department. The second part that was also important and noteworthy is only about half of this group were eventually shown to have sepsis. So what we're seeing here is an example of overuse of very broad spectrum antibiotics because physicians are inclined to give more antibiotics rather than less. And it's those sorts of examples that demonstrates what happens in real life. A very interesting part of this study design, and I find it very interesting and unique, is that the Institutional Review Board, the IRB, in the hospital waived the requirement for consent for individuals. Why? Because they saw this as standard of care. If I was the person presenting to the emergency department and the clinician judged that I needed those antibiotics, I was going to get this or that anyway. So there was no point in consent. So we've come to a point where we've normalized this excessive, very broad, less selective antibiotic treatments that we've driven more and more antibiotic resistance pressure. And then separately, there are other studies that show very clearly that increases in prescribing of antibiotics are very closely associated with increases of matching or corresponding resistance in bacteria. So what do we need? We need to pull ourselves back. We still need to try to give appropriate treatment earlier, but we need to be a little bit more targeted and we need to work on time. And that's again where syndromic testing comes in, because it allows us to do two things at the same time. It allows us to identify pathogens and it allows us to identify them earlier. And that means if we started broad, we can narrow. And if we started narrow, we can broaden. And we can calibrate. That's a very key word. We can calibrate our responses to individuals rather than mass management of the same patients, the same way, very different patients. So when we look at, as an example, syndromic testing, respiratory panels, for example, and how they could or might help us identify patients and then match them to their needs in terms of antimicrobial therapy, we could look at different clinical trials and we would see some interesting details. So, for example, in the context of hospital-acquired pneumonia, specifically in ICU, in one study, the investigators were able to show that using panels, using rapid diagnostics, enabled earlier identification of the pathogens responsible for the infection and then resulted in earlier changes. Very importantly, in this study, it shows earlier changes in both directions. So de-escalation as well as escalation, meaning that calibration or targeting is much more improved. On the other hand, there are other examples where studies did not show the same. Interestingly, they showed the same in terms of escalation. So doctors are very happy to give more antibiotics based on a result from the panel, but they're less likely to reduce antibiotics in response to the panel. So what does that tell us? What that tells us that there's a leftover effect. There's that shift towards one extreme that needs to be pulled back. Interestingly, one of the studies has included a sub-study of behavioral investigation, where what the investigators did is they ran semi-structured interviews with physicians and asked them questions about their views and their attitudes towards the test and towards their implication. And some of the quotes from those interviews are really interesting because they reflect the same persistence of those old ideas that we just need to give everyone lots of things. They reflected uncertainty and they reflected less familiarity and less understanding of those tests and their roles. A term that the authors used, and I'd like to quote in this discussion, is what they called the mind line. The mind line in their paper reflects those mindsets that took decades to build and now they just need to be clawed back. And they finish with a suggestion that we do need technology, but technology needs to come with BLUS. BLUS is the behavioral change. So we need clinicians to understand more and more the real potential of those tests. And as we go forward, start to apply those tests in a timely manner, and just as important, act on those results, up or down, in a timely manner. So we need to change behavior, we need to change attitudes, we need to build a better understanding of where we need to go next.